From the health sector's point of view, it's fundamental to move towards universal coverage. Currently, most healthcare systems make health inequities worse. And that for the health sector to have credibility to say that health inequities are something to act on, they first need to walk the talk and show that they're not making them worse in the first place. And so that's about ensuring availability, enabling barriers to access, and organising social protection. 100 million people are driven into poverty every year due to what they spend on healthcare services. This is not enough. If you're really going to address health inequity, you need to mobilise beyond the health sector. You need to give visibility to inequalities. You need to measure them, make sure they're visible. If you don't count them, if you don't know you have a problem, it's very difficult to move forward on the problem. And you need to reach the unreached. You need to consider why communities that often are marginalised and really have incredibly poor access to care, you really need to consider how they can access their right to healthcare services and to health. And so when we look at moving towards universal coverage, we're really talking about moving in three directions. So if you look at whether you're looking at insurance schemes or whether you're looking at a tax-based system, if you're trying to ensure that everyone has access to healthcare and can actually use it, because coverage is more than just access, you need to look at who is insured. You need to increase that proportion. You need to look at which benefits are coverage, so what's the depths of that insurance. And then you need to consider what proportion of the costs are covered. Are there co-payments necessary? And in a sense, in an ideal world, we want to move towards filling that box in all directions. Now, the second reform is in terms of shifting service delivery towards person-centred care. And that means putting people at the centre of the health system and organising services according to demand and not just supply. And this is a very difficult thing to do, but I think what we have learnt in the last 30 years is that some systems do this better than others, and that it's really about recognising that it needs to be, you really need to look at the power relationship. Too often, I think, in many healthcare systems, the power is vested too much in those who supply care or make the decisions as to where care should be provided, as opposed to the people who need services. They have a right to these services. What are their needs? How can they participate in decisions at all levels of the continuum of care? So it's not just in terms of having a safe environment to voice their concerns, get the services they need at the point of care, but also in terms of the management of health services, also in terms of being able to voice their concerns, also having a space in the way that health services policy is constructed. And it needs to be beyond just the health sector, because so many of the most important things that affect your health lie beyond the health sector. So it's also being able to participate into the decisions that affect those environments. Now, we're also arguing for comprehensiveness and integration, so that whilst a health system is very complex and there are many different providers, and that's fine, it needs to be coordinated. It needs to be able to provide some sort of response regardless of the problem that you present with. And that needs to be integrated in a single system. Continuity of care is very important, because so many problems and issues happen in healthcare services because there isn't continuity, because information isn't shared, because no one is taking responsibility to ensure that whoever you see has all the information they require to really address your needs and really ensure that they can provide a solution to the problem. Or if they can't provide a solution at their level, that they can refer you to someone who can. And this then requires a personal relationship, because it's really about the people that you see, with a well-identified, regular and trusted provider. To move towards this, you really need to organise this first level of care, what we call primary care, and that can be confusing, in a way that recognises the importance of that first contact with the health system. So you need to bring that first point as close as possible to people. In so many parts of the world, people aren't able to access services that are sufficiently close for them to get care in the time that they need. You need to shift accountability, so those people that you see first need to have a responsibility for an identified population, because they can't just be responsible for the people who walk in through the door. They need to be responsible for a population so that they're thinking about how can they ensure people are able to walk through the door when they need care, but also how can they ensure that care is available for people who can't make it to the door. And then it's really about, again, addressing these power relationships, that if you say this first point of contact is very important, you have to ensure that these people, the first people you see, have sufficient power and resources to really provide this comprehensive response. If you're saying, which is what we're saying, that these people are responsible for navigating people through the health system, whoever is providing care, you really need to shift resources and ensure that it's recognised that this is the fundamental pivot of the health system. So this is a slightly unreadable diagram, but what it really shows is that if you say that this pivot, the primary care team is the first point of contact, which lies within the community, and it can refer to a range of services, whether they're social services, community health workers, patient groups, self-management groups, who also lie within the community, but they also have to be able to refer you to all the other services that aren't immediately accessible within your community. Tertiary services, specialised care, diagnostic services, other service providers, the private sector, both not-for-profit and profit. And they also have a responsibility to navigate you through the system, and when you come back from these other services, to ensure that you're picked up, to ensure that those recommendations, the treatment that has been initiated is followed through. And again, I'm sorry that this is not so easy to read, but what we're really saying when we talk about people-centred primary care, to contrast to what we see as other sort of paradigms, is that people-centred primary care focuses on health needs, has an enduring personal relationship, is comprehensive, continuous and people-centred, and takes a responsibility for health of all in the community through the whole life cycle, also considering the determinants of health. And that really sees people as partners in managing their own health and that of their community, not just as recipients of care. But to do that, to support that very important level of the health system, you need support. You need healthy public policy. You need systems policy. So when you say you need to have power and resources as close to people as possible, that doesn't mean you don't need a strong central structure, because you do. It's not an either-or proposition. You need strong systems at the central level to ensure procurement, to ensure adequate health resources, to ensure that you know which medicines are essential, that you can retain health workers, that you have a strong centralised public health systems so that are still necessary. Outbreak control requires a very strong central response. You also need public health policies, which some of these are your traditional mass public health interventions: iodine fortification, tobacco control, water control, food safety, air quality controls. But you also need this new realisation, we have a lot more knowledge as to how other sectors impact on health now. What are your employment policies? What do trade policies mean for the access to commodities that impact on health, both in a beneficial way but also in a damaging way? How are you going to structure your cities and plan your cities to ensure that people can access public transport or use active transport to, so that it's safe for them, firstly, to access the services that they need? What's people's access to healthy nutrition? It's not just enough to have health education messages that say that you need to exercise more and eat well. What are the actual environments that enable you to make those choices in a positive way? And really, when we're talking about health and all policies, when we say that you need to consider the impact of health and all policies, we're talking about addressing the social determinants, which I'll briefly consider in a moment. And finally, you need effective leadership, and you need to invest in this leadership. It's not just the Ministry of Health, it's not just the government. You need to mediate between all stakeholders. You will represent a very powerful, a very strong, a very informed constituency, patients. There are many other stakeholders. Your resources need to be recognised. The government still has a responsibility to ensure the right to health. It still has a fundamental role, but that doesn't mean it has to do everything. But it does need to steer, it does need to negotiate. It can't just be top-down control, command and control. It needs to make the most of all of the resources in society to ensure the right to health.